So today, first of all, welcome to our third session of these CHARM database seminars. I'm calling it CHARM because that's really the name for the group of people that we constitute. Child Health Advances from Research with Mothers. This is a Jean Curver acronym. Jean is always so good at developing acronyms. It describes us, and we have several cohorts, most notably March and Arch, which have been described previously, and soon to be added to the new ECHO 2 recruitment, which will enroll another 500 or so mothers in Flint, Detroit, and Traverse City. So I'll first talk a little bit about study design issues, especially as they apply to analyzing our CHARM data. And then sometime in the middle, Nicolino Smith of Henry Ford will tell us about studying sleep in pregnancy as one example of something that we can make a special study of. And we have really actually very good sleep data on mothers in our cohorts, especially in our March cohort, not so much in the Arch cohort. Okay, so I'll talk a little bit about study design in general. And let me just point out that although Arch and March are very rich in data, one could, in principle, and this has actually been done with appropriate support, add new modules to the database we have, such as new laboratory assessments, new clinical assessments, new surveys. These are all feasible with appropriate support and have been done actually already in add-on studies to Arch and March. So this is I imagine this is going to be rather small. I will talk only briefly from this slide.
Nigel, I don't believe your slides are advancing in any way.
Oh my gosh. Oh dear.
Maybe you could stop sharing and try again.
Okay. So let me start from the beginning. So do you think I should just go share screen and pick up my slideshow and put it on? Why is it not? Do people see anything at all?
Yeah, we see the same thing we saw before with just the first 1.5 slides.
Just so bizarre. What if I, Jean, what if I sent the slides to you or to Kylie and see
now you're advancing them.
So here you can see them. Okay.
Yeah.
All right. Well, so can you see this slide?
Yes.
All right. Okay. Well, we'll live with that. So this is the typology of study design I developed for use in my intro epi teaching. So some of you have seen this before, like Ali Glazier has seen this before. The basic, I'm going to go over this in more detail, but this is just a schema of how to think of study designs. And I really think study design is important, especially in these days of big data, when people have a habit of just going in and see what's in there. You need an architecture for any research study. You need a framework. You need, otherwise it'll just be a pile of bricks, like a building without an architectural design. So studies can be analytic or descriptive. I'll explain what that is in a moment. And within the world of analytic studies, they can be experimental or observational. And there are nuances to that too. Then the nature of the unit you're studying could be either ecological or individual. And then within that, there are certain study designs that I'll emphasize, in particular cohort and case control studies, that can be added to a large prospective cohort, such as our cohorts are. Now, let me go down. We'll move it down. Now, do you see the next thing? Okay, thank you. So I'll take you through what I mean by descriptive versus analytic, what I mean by observational versus experimental, and what I mean by ecological versus individual studies. So descriptive studies are essentially a one variable study. They're essentially describing the frequency of something, usually disorder, sometimes an important health-related exposure, and arraying it against commonly available features that you generally get without too much difficulty, such as geography, race, ethnicity, sex, and some sociodemographic features. And descriptive epidemiology is not very sexy, but it can be very useful a very useful step in trying to develop an analytic hypothesis testing study. Simply knowing the descriptive epidemiology of condition makes it feasible for you to design a better study about that condition. And I think I've seen examples in epidemiology and medicine where a study has gone forward about a condition where the descriptive epidemiology was either not known or not appreciated, and people fell into some traps with that because they didn't know quite what to really look at properly. And I should say that the March study is especially suited to descriptive epidemiology because it's population-based. Now, analytic research is what we mostly do. Analytic studies in epidemiology have two variables, an exposure and an outcome. And ideally, we have a clear etiologic hypothesis specified in advance. This exposure is thought to increase or decrease the risk of this outcome. And the simplest, whoops, what did I do there? Do you still see me? Oh boy. Do you still see my slides?
Yes.
No, I can't see my slides. Isn't this the craziest thing? Let me see if I can get this one down. Okay, now I can see them. Better not click anything. Always a disaster. So it's in the simplest form, we actually hypothesize an association. There is an association between an exposure and a disease, but really, in order to really properly undertake a study, you really have to estimate the size. You have to approximate the size of the association, because that's required in order for you to know what the sample size is that you need. If you're talking about a 40% increase in risk versus a four-fold increase in risk, those will require different sample sizes. Now, within the world of analytic studies, you can have either observational research or experimental research. But in all forms of analytic research, even in randomized trials, you must identify potentially confounding variables in advance of the study. And this is where descriptive epidemiology comes in, because it gives you some sense of what you have to control for. Now, in observational studies, the point about it being observation, the exposure is not assigned by the investigator. For example, you could study IQ in children born prematurely, compare that to the IQ of children born at term. That's an observational study. You did not assign prematurity. You cannot assign prematurity. And of course, since most exposures in epidemiology cannot be assigned, we know our largest chunk of studies is observational, not experimental. Now, we do experiments in epidemiology, and the term experiment indicates that the investigator assigns the exposure. And in epidemiologic research, and I really want to underline this, not necessarily in every form of research, we only use the term experiment to describe a randomized trial in which the investigator randomly assigns the intervention. And we have a term for studies, interventions which are not randomly assigned. We call them quasi-experiments, and there are many forms of them. But for example, you might often in educational research, quasi-experiments are greatly used in educational research. You could have a classroom getting a new form of way of studying, comparing to a classroom that just had the conventional means of doing the study. That would be a quasi-experiment in our terminology, not a true experiment, because in our terminology, in epidemiology, a true experiment requires randomization. Ecological studies, not much relevance here, but I'll show you in a moment that it is important to think of the term ecological. In observational studies, the study becomes ecological when the unit of outcome is a group. So, for example, if you were to study, as has been done, the distribution of Lyme disease incidence by county in the US and the distribution of tick species, you'd find a very, very high correlation. And that would be a pure ecological study. The outcome is a rate within a county, not an individual. And in experimental studies, and you may be surprised to hear that these are done, you can also have ecological trials when the assignment is to a group. I know of studies in Nigeria and Indonesia in which the unit of assignment was a village. You randomly assigned 10 villages to get something and 10 villages not to get something. And some very important research is done that way. Now, what we're most interested in, of course, is individual studies, and where the unit of outcome in the analysis is an individual, not a group. But it's important to remember that you can have an ecological exposure in an individual study. And this is why it's important to recognize that ecological studies are defined by the ecological group is the outcome. For example, if we're studying childhood asthma, we can look at an individual exposure, let's say smoking by the parents, or an ecological exposure, such as urban or rural residents or residential exposure to air pollution. Those are not measured at the individual level. Air pollution is an ecological exposure. It applies to a region or a group of places. Even within a residence, it's not individual. So we do have in the research we could do with March, we do have ecological exposures often obtained from state databases describing air pollution, water pollution, and such. Or sometimes it's weather conditions and other such things that operate at the ecological level. Now, a key issue in all designs is the study sample. How do you get the people you are studying? Every study begins with selection of a study population. And it's really intriguing to me that when I've taught epidemiology, I've looked for the topic of how do you select your sample in epidemiology textbooks, and very few deal with this. It's kind of an omission in epidemiology. There's one older textbook from quite some years ago that actually does talk seriously about sampling. So, one of the most important reasons to think about who's the study sample is to always ask, who am I not studying? Who has been left out of my study? Unfortunately, we often leave out sometimes the most important people to study. Now, ARCH is a conventional clinic-based study, but in pregnancy studies, clinic visiting is not quite as selective as it is in other areas of research, because 99% of pregnant women attend at least one prenatal care visit. And I should, as an example of where our sampling process can change the population we study, in March and ARCH, every woman was eligible to be recruited at her first visit whenever it took place. She could come in at the 39th week and we would enroll her. In the new ECHO 2, unfortunately, I think, we are restricted to recruiting women who come in for prenatal care before 20 weeks. Well, that's all and well, but then you leave out the approximately 10% of women who make very late prenatal visits after 20 weeks. Now, those 10% of women are probably important to study, because women who come in late for prenatal care are a very special category of women in many ways and have stresses and troubles in their lives that we really ought to know about. Unfortunately, we tend to, in an attempt to achieve certain kinds of precision, we can sometimes leave people out of the study we should be studying. So that's unfortunate. But anyway, ARCH and March, those women who come in late for prenatal care are only included. The only women we lose, and it's very, very small, is the women who come in for no prenatal care at all. But that's extremely rare, 1% or less. And March, of course, is a population-based study. So its sampling frame is greatly superior to most studies. It is less likely to exclude people that we like to study. So let me just turn now quickly to the main forms of observational research that we will probably use in CHARM. I would say that the largest category is a retrospective cohort. What do I mean by a retrospective cohort? March itself were prospective cohorts. But when we come at them after the fact, as we are now, then they become to us retrospective cohorts in the sense that the exposures and the outcomes have already taken place. We can't kind of design around them. They are what they are. So this really takes the shape of a retrospective cohort. So we would extract exposure and outcome data from the database and examine them in cohort fashion. That is to say, from exposure to outcome. That's the definition of a cohort study. It is directionality from exposure to outcome. The other side of things is the case control study, where we study from outcome to exposure. We go backwards in time. And the form of case control study we have available to us in March is the nested case control study, in which we also extract exposure and outcome data, but we look first at cases of the thing we're interested in and match controls and look back to see what exposures of interest are present in cases and present in controls and with what frequency. Now, we call it nested because we don't select from the entire population. We select controls and cases only from the cohort we have available to us. Now, the advantage of a case control study is you can study something that's a little bit rare, that's not so common. And if you need to do a special test that was not tested originally, let's say you have a serum sample in pregnancy on cases and controls, you can go back and then run tests on those and quite efficiently establish associations between exposures and disease. That would be much less expensive to do than to run the test on every single person in the study and then look in cohort fashion at exposure and outcome. Cohort study, the retrospective cohort approach is very useful if you're studying stuff. Everything you're studying has already been collected. But if you need a new variable, you're often better off thinking of a nested case control design. Other designs you might be interested in, descriptive. I don't think you should forget about it. It's probably not the first thing that jumps up to mind, the descriptive epidemiology. But really, if the condition has not been really well characterized, a good descriptive study, especially in a population-based sample, can be very useful. Cross-sectional studies. Cross-sectional studies means when the exposure and the outcome, whatever they are obtained at the same moment in time. Very problematic because you can't always tell. You actually usually cannot tell which is the chicken and which is the egg. What's the exposure and what's the outcome? Let's say you, for example, compare data elements, different women answering different surveys at the same time. Is there a correlation between those two forms of survey, the two results of that survey, or some laboratory test? So we have the opportunity to do cross-sectional studies, but as I say, time order is uncertain, and you don't take advantage of the longitudinal nature of our cohorts. Nonetheless, it can be a preliminary look at something you might find interesting to study in a more, perhaps in a more rigorous way. And experiments. It might be feasible to mount a trial based on cohort data. And sometimes this can be very efficient because you can select participants of interest from the cohorts, and they will have a lot of background information that you don't have to bother to collect because it's already there. And even outcome data may become available as participants in your trial are also assessed as part of our ECHO study. We don't have any trials mounted at the moment, but I don't think it's unfeasible to be done. But of course, it would require external funding and support. So as you design your research ideas, consider the design that would most efficiently test your hypothesis. And I say the most obvious design is a retrospective cohort approach. You begin with defining the exposure, and then you ascertain the frequency of the outcome in the exposed, the unexposed. If the outcome is rare, you need special testing to ascertain exposure, consider a nested case control approach. Now, when I say matching controls, that's a tricky business, matching controls and case control studies. And if anybody really gets into this, I want to let you know that I have any number of teaching points about control matching in case control studies, but that's a subject for another time. So before we move to Nicolina, let me just ask if anybody has any questions about these study design points, a few study design points I've made. Anybody? I'm not sure I can see all the participants to see if a hand is up, so maybe just yell if you have a question. No questions? All right. Very good. I'm pleased to see there are no questions. Usually when I talk about study design, there's lots of confusion. But anyway, okay, so let's move on to Nicolina. I will stop sharing. And Nicolina, you, I take it, will probably have some slides as well? Yes?
Yeah.
Okay, so you can start to share.
All right.
Can see that.
Perfect. So my name is Nicolina Smith,
And thank you for allowing us to discuss our idea today. I am a maternal fetal medicine fellow at Henry Ford in Detroit, Michigan. And I've had an interest in sleep medicine and how it can affect pregnancy. So today we'll be discussing exploring the impact of maternal sleep quality on placental and neonatal weight. So I want to start by discussing terminology. It can get a little bit challenging when you kind of get into the literature with sleep disorders. There's sleep disordered breathing, which is kind of a blanket term, which includes OSA or obstructive sleep apnea. It can also include central sleep apnea, as well as any other forms of hypoventilation or habitual snoring. And then sleep apnea is very specific, and you diagnose this based off sleep studies, and there's certain criteria. And then there's a whole nother section, which we're not really going to talk about today, but looking at other sleep concerns in pregnancy, such as insomnia. But what we do know is that when we have this fragmentation of sleep, you get deoxygenation, and you also get elevated carbon dioxide levels, which would subsequently cause an inflammatory process. And we do know that there are adverse pregnancy outcomes related to this disease in pregnancy, and that includes hypertensive disorders of pregnancy. So that ranges anywhere from gestational hypertension to severe preeclampsia, gestational diabetes, preterm birth, fetal growth abnormalities. So both, having fetal growth restriction or macrosomia, which is a large fetus, as well as fetal heart tracing abnormalities. So I'm going to hone in on the literature and what it states about fetal and placental growth, since that's what we're interested in studying. But OSA and sleep disordered breathing have both been shown to correlate to fetal growth problems. There has been one study to date which has specifically looked at placental weight in obstructive sleep apnea, and it evaluated 53 placentas, and they actually found an increased weight, which was, which is not necessarily what I would hypothesize that would happen. There were some flaws to the study. It was a small sample size, and there was an inability to control for confounding issues, particularly gestational diabetes, which would make sense for the increased weight of the placenta. Other drawbacks were that it was not performed in the US, so the majority of patients have normal BMIs and minimal comorbidities, so it's not very generalizable or relatable to the patient population that we're used to in the United States. Other studies specifically looked at different biomarkers that are secreted from placentas that are associated with obstructive sleep apnea. Dr. Bourgeois has done a few different studies, and they kind of look at inflammatory markers and which ones are more prevalent. And it's been relatively established that it definitely is an inflammatory process going on. However, during these studies, placental weight was not measured. And in fact, in the limitation section and future research, ideas or endeavors, they do comment that it would be useful to just look at the placental weight itself. Few studies specifically examined the impact of sleep quality on these outcomes. One review did conclude that there is no difference in birth rate for fetal growth in mothers with poor sleep quality. However, again, the big limitations to the review, this research review, was that the largest sample size was an N of 633, and the other studies associated had much, much smaller numbers, just in the double digits. So it's very challenging when you do have such a small sample size. Furthermore, sleep is very subjective and highly prevalent, particularly in pregnancy. So it could be very challenging to study. So this does beg the need for larger longitudinal studies to thoroughly investigate these outcomes. So our clinical question, does the quality of sleep influence placental weight, fetal placental ratio, birth weight, weight, and then to further stratify this by race. And the reason why we would like to stratify this by race, more recently, it's been noted that Black mothers, because of racial weathering and just inherent stressors of pregnancy, their quality of sleep is significantly worse than their white counterparts, which then could be the reason why our maternal mortality rates are so high for Black mothers. Just kind of one of the things that could be causing that. So our hypothesis is that poor sleep quality will negatively impact the neonatal and placental outcomes, including decreased placental weight and decreased birth weight. So this kind of just depicts the overarching hypothesis. We believe that poor sleep quality does lead to an inflammatory process, which then will cause changes within the placental function, which will be, decrease placental weight and birth weight at the time of delivery. So why this is clinically relevant? A lot of the downstream comorbidities associated with poor sleep, if we can address poor sleep and prevent some of these from happening, it could help our moms and their outcomes, as well as the fetal or neonatal outcomes, and also healthcare dollars. A lot of healthcare dollars could be potentially saved. So in regards to fetal macrosomia or large babies, when moms get this diagnosis, it is anxiety provoking because we have to counsel them and the fact that the baby could get stuck in the birth canal, which could be a catastrophic delivery. There are oftentimes labor abnormalities for these patients, and they will have very long, prolonged labor courses, and ultimately a majority of them do end up in cesarean delivery. Fetal growth restriction, when this is diagnosed, you have to have increased pregnancy surveillance, so weekly ultrasounds, weekly antenatal testing, and again, that causes a lot of maternal anxiety, and it's very challenging to get to these appointments. We also worry about preterm birth, as well as if a baby was growth restricted on top of being born prematurely, they have increased neonatal complications. Then for hypertensive disorders, again, this is a major factor in us needing to deliver moms preterm. Long term, these patients also have cardiovascular morbidities. They need prolonged hospitalizations, sometimes months they spend with us in the hospital leading up to delivery. And hypertensive disorders is one of the top 3 causes of severe maternal morbidity. Lastly, preterm birth. So again, all of those above factors can lead to preterm birth. But whenever we have that, the babies have to stay in the NICU for a very long time. We worry about intraventricular hemorrhage, necrotizing enterocolitis, respiratory distress, but then even long-term effects for these children and health issues they're going to face for their entire life. So our goal would be that hopefully with our findings, it will just validate the need for continued efforts to develop a screening tool for sleep disorders of pregnancy that is validated specifically for pregnancy, as well as increasing referrals to sleep medicine for diagnosis and treatment. So again, to revisit the outcomes that we are interested in: birth weight, placental weight, fetal placental weight ratio, and then these differences based off race. So the specific questionnaires that are of interest are within the ECHO cohort. The ECHO maternal sleep health questionnaire, specifically question 5 addresses snoring. The PROMIS sleep disturbance questionnaire, questions 1 to 3 address quality of sleep. And then the PROMIS sleep impairment questionnaire, and all of those questions, kind of relate to how well the mom is sleeping. So the available placental and sleep data is about 500 unique pregnancies within the ECHO cohort. The number is higher for birth weight, only because not all cohorts in the first cycle had placental data collected. And then the CHARM cohort will have even more detailed measures of sleep in the second trimester. However, we're still trying to compile the different scales, and the sample size will vary depending on whether or not placental weight was captured for these individuals. These are the questionnaires. So again, the method is to evaluate maternal sleep quality with either the echo or charm data using the questionnaires that we have on hand. And then we want to examine the associations between quality sleep, placental weight, neonatal weight, and the placental fetal ratio. And here are the references. I just wanted to acknowledge the team that's been helping me with this idea and kind of develop it. Dr. Strawn, Dr. O'Brien, Molly Chrisman, and Dr. Ma. So thank you.
Great. Very interesting, Nicolina. Are there any questions? I'll have some, but I would want to ask the group first to weigh in. Any
There's one
thoughts?
in the chat.
Yes, there was a question in the chat. Looked like it got answered. The weathering hypothesis. I can say a little bit about that. Marie has answered to some extent, but this has been mostly studied by an investigator at the University of Michigan named Arlene Geronimus. Some of you may know Arlene. And she has argued that the cumulative effect of all sorts of social and economic disadvantages kind of weathers people. It makes them have things happen sooner than they would happen in other people. And she argues that a lot of the difficulties faced by Black women represent that the disparities in perinatal outcomes represent that kind of weathering effect. And she has some data in support of that. And she's actually just recently published a book on this, which I have. So it's just a way of looking at the disparities that we have to try to unravel in the perinatal period, as I understand it. Do you want to say anything more about that, Marie?
No, I think that's a very good explanation, Nigel. Yeah, just the idea that people are worn down disproportionately.
Yeah, disproportionately. Karen, does that clarify a bit?
Yes, thank you very much. I appreciate it.
Yeah, and I would recommend Arlene's work, which was for a time very controversial. There were people who attacked her for saying that she argued, for example, it might be sensible in some situations for African American women to have their babies at a younger age. And this began to get people all up and hot under the collar about encouraging teenage pregnancy, or which to that effect. So Arlene came up for some pretty nasty criticism at one time. Her book is just out describing her thoughts and her data. So, which I'd recommend. She's a very thoughtful investigator. Are there any questions of Nicolina about her research, or some thoughts, ideas, to stimulate anyone to ask some questions?
I have a question, actually, Nigel, for
Sure,
Nicol.
Ellie, go ahead.
So we're looking specifically at the outcome of miscarriage in a nested case control study using March data, ARCH data, and then combining with another cohort in Boston. So I'm curious, I did just a quick little search of, maternal sleep quality and the outcome of miscarriage. And I'm just wondering if you had, in your work and your research, come across anything that stood out to you, in terms of perhaps sleep quality and pregnancy loss early on.
I have not come across anything specifically addressing that question. Dr. O'Brien's on the call too. She knows the sleep literature a lot better than I do. So, but I have not. I think that would be interesting to look at because, again, it's such an inflammatory process. But you also have to just be very careful to control for confounders. Mainly obesity we know is associated with early trimester pregnancy loss, as well as hypertension and diabetes. So you kind of get this metabolic disease of pregnancy, which encompasses, obesity, sleep apnea, hypertension, diabetes. So just being able to kind of suss that out would be very important to show, just a correlation only, just based off sleep. But it would be very interesting.
I think that's a great question. There's very little in the literature looking at pregnancy loss in terms of maternal sleep. We've just about to submit a paper from a big cohort showing, and this was only like baseline self-report maternal sleep, showing that if I remember rightly, there wasn't much with sleep duration in pregnancy loss. It was more the sleep timing and the poor outcomes in the women who had successful pregnancies. So that will be going in for submission, I think, this week. But that's an area that absolutely needs to be looked at. Really
It's
important.
very interesting. Thank you. I'm having a lot of thoughts now, and even just in my quick search, I found very little in terms of, measuring for that association. And I did have a follow-up question on, sleep quality kind of just in and of itself as a maternal state. Have you found anything in the literature looking at things like social vulnerability, maybe ecological factors that might be related to those individual level, experiences, anything like that you've come across?
I haven't. Sorry, Nicolina, do you want to go ahead and take a
That's
shot?
it kind of the project that you and Dr. Pitts had done together that we were trying to get published. It kind of demonstrates that sleep quality does differ amongst races. And again, just kind of goes into the weathering effect and how, based off your security and where you live and the other stressors at home, you're more vulnerable to these sleep disturbances and you don't always realize that they're there. But yeah, that's of things that are actually published in the literature. I think it's very few. That's just a study that I was able to read. My mentor and Dr. O'Brien worked on together at U of M. So
Yeah, there's very little there. I totally agree. And I think because sleep quality is pretty much universally bad in pregnant women, that, it's so frequent, it's something like 70 to 80%. Sometimes it can be hard to tease out, some of those other vulnerabilities that you mentioned without really large sample sizes. So that would be sort of an ideal thing for like large cohorts like this.
Indeed, and even perhaps something that could be extended into, the larger ECHO project, maybe collectively looking at multiple cohorts would be in order. It's a really interesting topic. Thank you so much.
Just to orient you, Ali is the project director for a study that's an add-on to our March and Arch cohorts, looking at the miscarriages that took place. After all, ECHO doesn't study miscarriages, it's interested in child health. So we said, well, but we have miscarriages and we have lots of data collected before the miscarriage, which is unusual, as it turns out, including blood samples. So we've mounted a case control study along with another Boston cohort. And so I think, that's another set of exposures you might be interested in looking at, Ali, and that's a very good thought. I should say, talking about the data we have available, Nicolina, we mostly have good sleep data in March, not Arch. I don't believe we got much in pregnancy in Arch. Maybe we have a little bit. But March we have the data that ECHO wants us to collect. And in addition, I think through Dr. O'Brien's team, we added more detail. It may not be fully available for every single March participant. We have, for quite a few of them, a bit more detail than ECHO overall has on sleep. We have over 1,000 March participants. We have follow-up data on increasingly more and more of them, at least 80% of the kids who have reached the age that we can follow them up on. So that's available. We have, of course, birth weight and gestational age universally. We have placentas on many. You said, your slide said, Nicolina, 500 placentas in ECHO. Well, we actually have nearly 600 from March alone that were processed in the placental analytics laboratory by Carolyn Salafia. And then we have additional, at least 100 for where we have reports from the hospital's placental pathology in the hospitals for those placentas that were seen in pathology before they went to Carolyn. So we probably have, we're quite rich in those kinds of variables that you say are lacking in other studies. Of course, we also have, a slew of control variables to look at. Every kind of SES variable you would like, we have obtained, I think. So it seems like a good place to look. I think looking at birth weight and gestationally fetal growth, placental size, those are great. But you can extend it to look at postnatal findings as well in terms of child health or even maternal health, because we do ask questions about maternal health. And you could probably also look at correlates such as you've been talking about, maternal anxiety, stress. Those are available to us, and they could be correlated actually almost in a cross-sectional way, as I described earlier, in women who we ask about their sleep. We also ask about their anxiety and their stresses and so forth. So that's, I think this is a good topic for the March database.
Indeed. And I just wanted to add also that in terms of a cross-sectional, Nigel, you mentioned a cross-sectional analysis, we have the data collected on adverse childhood experiences and also racial discrimination experiences. So that could be something that you may want to consider, along with assessing sleep quality.
Yeah, and Gwen has kindly put in the chat a reference to that very topic. Relationships among cumulative trauma, post-traumatic stress, sleep quality, and perinatal outcomes in African American women, published by an investigator from Wayne State. So, if you want to tell us more about that, Gwen.
Oh, sure. Yeah, that Nancy Hoff is in the College of Nursing at Wayne State, and this was her dissertation, but it has a lot of good information in it regarding some of the issues that we're touching on today.
Great. Has she published some of this yet?
I was trying to search real quick. I didn't find it, but
Okay.
I found the dissertation, but I don't know.
Okay, Marie O'Neill has her hand up. Marie.
Yes, hi. Sorry, there's also a cat speaking in the background. But I was just thinking also about physical exposures. I saw Teng Fei Ma is listed on the team that Nicolina has, and I'm just thinking about noise and light at night and some other things that you may be able to estimate exposure for that you would anticipate having something to do with sleep quality and ability to sleep. And I'm wondering whether that's something that the team has thought of, or maybe Nigel or others who are more integral to ECHO could comment on whether those exposures are available or for the March participants.
Do you mean things like sleep quality obtained in the middle of the summer when light is in Michigan still present at 9:30 p.m. and stuff like that? Or are you thinking of some other form of light exposure?
Well, I think that, yeah, the day length is important, but I was more thinking of, there is evidence, people suggest, keep the room very dark. And then if you're living in an urban area where there's a lot of street lights, or if you're close to a highway and you have, intermittent,
I see.
like headlights, things like that was what I was thinking of.
I see. I think at the individual level, we're not likely to have that, but at the ecological level, we might. Louise, do you have any thoughts about that?
I mean, that's another good point. And there is quite a lot of literature looking at like sleep in sort of neighborhoods. So from an epi perspective and sort of different types of neighborhoods and how they can be linked with poor sleep. So that there's definitely literature out there on that. Not in the context of pregnancy, but it's out there. So that would definitely be something that could be pulled together.
Right. It's thank you. I want to also thank Nicolina, especially for coming forth with our first look at a topic, a specific topic within March. And this is a very good topic. I think we have a data set that could, it sounds like from what you say, maybe contribute more to the literature than we have so far in terms of both correlates of poor sleep and outcomes of poor sleep. And I think probably a grant proposal could be written around this. I can imagine easily making use of our database, focusing specifically on the perinatal outcomes, which is what you focused on, Nicolina. And I think the next step is to try to make it into to an Ames page, and we have the slides from the last time when I talked about how you create an Ames page for NIH, focusing on getting the background and getting specific questions and talking about the potential impact if you actually do address this problem. You even spoke about that as possibly leading to a screening test for sleep quality in pregnancy. I think Louise puts her finger on it when if women in general, pregnancy is not their favorite time of their life to sleep. How do you pull out what is particularly pathological among sleep concerns? So that's obviously a really tough exercise. And I'm sure Louise and your team at U of M, I'm sure you've been thinking about that a lot. So it's always good to have that kind of expertise to back up how we measure sleep quality. That's going to be a tricky thing. And I hope some of you at this audience might say, hey, that intrigues me. Maybe I can get in touch with Nicolina or Louise or Jennifer Strawn and help out and participate, and also giving you enthusiasm to come up with your own ideas to use in March. Any more questions about sleep or comments or suggestions to the team? Okay, I don't know if there's anyone right now on this group who wants to say, next month, I'd love to talk about, I won't put pressure on anyone, but if you do wish to suggest a topic,
I would love to talk about the social vulnerability index that we're working on, Nigel, if that's all right. I think that could be very interesting to the group.
Right. We could talk about that. Absolutely. We could, I was thinking especially of ideas that actually are about a study. Now you could say that social vulnerability index is just a measure, but it's an important measure. You're quite right. But maybe we can construct a study out of it, Oh, I just remembered something I meant to say to Nicolina and I forgot completely. I'm getting old there. We have inflammatory markers obtained, multiple inflammatory markers obtained from maternal blood spots in pregnancy on a very large fraction of our March mothers. They were done by Reina Ficharova at Harvard. High quality stuff. So we can add an inflammatory, if you see inflammation as a mediator, as you suggested, between sleep and adverse outcomes, we can examine that in quite a few women. So as you guys draft up an Ames page, keep that in mind, and we can find out for you exactly how many women have each of the measures, the sleep quality measures, the placenta, birth weight and gestation age, that's pretty much everybody, and also the inflammatory markers obtained. But we do have a rich database in terms of inflammation.
Thank you.
Okay, any other thoughts as we wrap up here?
I just wanted to say, Nicolina, I thoroughly enjoyed your presentation. And ever since I've been working with CHARM, I've just been so intrigued and fascinated by all the different stressors that can affect prenatal outcomes.
Oh, yeah, that's true, Shatoya.
Yeah.
There's so many to measure. And this is a little bit what Ali is talking about with his vulnerability index, trying to aggregate together many of them into a kind of measure, especially an ecological level measure. Which we particularly were focused on because we have two cohorts and people measure anxiety and stress in different ways. But on the ecological level, if you can get an index that says how stressful is the neighborhood, the census tract in which the woman lives, and you can quantify that to some extent, that's a really lovely measure to have. And maybe we will talk about that next time a little bit. And notice, please, everybody, there's some nice citations available in the in the chat. Someone is asking of FFQ data. Do you mean by FFQ food frequency? Ilse?
Yeah.
We do, well, as I don't know if Jean is still on, but Jean is our authority on nutrition. We do have data on food intake, nutritional dietary qualities. I'm not quite sure exactly. I don't know it as well as Jean Curver will know it, but you can get in touch with Jean, and she will tell you about the food frequency data. We're very, very interested in nutritional issues.
Okay, will do. Thank you so much.
I mean, the PI, Jean Curver, has a PhD in nutrition and is a registered dietitian, so you can't get any more close to nutrition than we are in our cohorts in Michigan. So great to have you on board on that, Ilse.
Thank you so much.
All right. Well, thanks very much, everyone, for attending. Thanks, Nicolina, for presenting your ideas. They're great, and Louise and the team at Michigan, and all of you, and Jennifer, and Galit, who's, I guess, part of your team. I didn't see her name up, but she's part of the team, one of our former graduates. So great. So we'll see you next time, second Monday in April this time at 1 p.m. And there'll be something fun to talk about then too. So take care, everyone.